So the first message actually is when with severe upper GI bleeding, when should you consider doing endoscopy? This is a Scandinavian study that I'll refer to, but remember it's based on the ASA score. I list 5 ASA scores. These are surgical scores, which you're probably familiar with. But in this large international study from Denmark, they looked at the best time in different ASA groups, that's 1 and 2 on the bottom, versus ASA 3 to 5 on the top, and inpatient mortality. So of course these patients were all in the hospital, they had different kinds of upper GI bleeding, but the window of doing endoscopy and having the lowest mortality, particularly in the high-risk group, the top curve, would be between about 15 hours and 24 hours. That allows the patient to get resuscitated, and those are hard data. The second issue is this one of transfusion. How much should you transfuse a person who has upper GI bleeding? There's been a trial reported in the New England Journal by a Spanish group that says you shouldn't transfuse people unless their hemoglobin is below 7. This is a difficult trial, randomized trial with a lot of exclusions, and if you look at the data, the death rate was only significantly higher in the patients who had good Child-Pugh scores, that's A and B, but not in other groups of patients, including Child-C, ulcers, etc. So what we did is looked at unselected patients, a large group of them, to see whether those data held up locally. And these are the results. For non-variceal patients, there were nearly 1,200 of them. In fact, the p-value for transfusing more and having an advantage was at the 0.05 level. So if you transfuse patients, and our target was a hemoglobin of 8, you actually reduce mortality in non-variceal patients. That probably is related to cardiovascular status and everything else. These are unselected patients, ASAs 1 to 5.5. With variceal bleeding in the middle, didn't make any difference. The odds ratio of transfusing more was a little bit lower. It decreases the mortality by 14% or so. What were the factors for death with all diagnosis? Well, the first is greater severity of disease, which either relates to Child-Pugh and varices or prognosis score, such as we use. Secondly, the PTT that's elevated. Thirdly, the INR or PT that's elevated. Fourth, low platelets. And fifth, inpatient start of bleeding. But any of the other factors that we looked at in a multivariable analysis, including 30 of them, didn't make any difference. I now want to remind you about the Forrest classification, or in our case, stigmata of hemorrhage descriptively. You're familiar with these, including spurting, oozing, visible vessel, adherent clot, flat spot, and clean ulcer base. And I'll refer back to those because one of the main messages is not what these look like, but what's underneath them, particularly after you treat these. So what are the mechanisms for endoscopic hemostasis of lesions with arteries? That's non-variceal lesions. Well, whatever we do chemically or touching or heating, it activates the platelet coagulation. Many of these, including heat, cause secondary edema and swelling and compression. With epinephrine and other sclerosants, you can have arterial constriction, which is helpful. And then tamponade of the vessel is what we do mechanically with touch probes. Coaptive coagulation results. And on the bottom, we think we can mechanically close the underlying artery with clips, but we're wrong part of the time. Long time ago, based on laboratory studies, we studied coaptive coagulation, which is welding arteries together, and in the lab using heater probe or bipolar technology that doesn't erode the vessels, low heat energy, firm tamponade, you can compress a vessel, interrupt blood flow, and weld arteries together that are up to about 2 millimeters in diameter. We think we can do that clinically also, but it's never been documented so carefully. A long time ago, we did a controlled study in which patients with actively bleeding, spurting type bleeding or visible vessels were randomized into 3 groups in this large randomized study: the medical group, bipolar, and heater probe. And on the top line, the initial hemostasis was quite good with either the bipolar probe or the heater probe. But further bleeding requiring transfusion was fairly high. In the heater probe group, 24%, bipolar, 40%. We thought we were good. We thought we knew what we were doing. We never had a good explanation of that until recently as to why that should not be better. Of course, it's always better than the medical surgical group, where you see 60%, 66% further bleeding, 42% requiring surgery. Then clips came along, and this is a cartoon about how we think that the clips work well. If you have a stigmata like a visible vessel, the idea is in the ulcer base is a clip on either side of that to interrupt blood flow and ultimately to clot the underlying artery. How often are you not able to do that? Well, it's about the same as the heater probe and the other, and I'll show you the results. 25 to 30% of the time, you don't accomplish that of interrupting underlying blood flow. How do we know that? We have this Doppler probe, which is commercially available, and this will allow you to track the arteries, and in a case of veins with varices, you can do that also. This is simple to use. It's, you touch next to the stigmata of hemorrhage and go out laterally, and you can hear an artery. We usually use a superficial setting of up to 1.5 millimeters, although tangentially you sometimes have to use an intermediate setting, which is up to 4 millimeters. So you can not only answer the question, in this case, is there underlying blood flow, yes or no? Number 2, what's the direction of the artery? So you know if you're going to put clips on, where to put the clips per the previous diagram. We finally had an answer to the question using this Doppler probe as to why we weren't previously successful. But first, at baseline, looking at the different stigmata of hemorrhage, spurting, visible vessel, clot, or oozing, or flat spot alone, at baseline you can see the detection of the arterial flow varies from spurting 100% down to about 47% arterial blood flow with oozing, about the same as flat spot, with the other stigmata being in the middle. The answer to the question that I've previously posed about why we weren't doing so well is illustrated here. Of the patients who had baseline arterial blood flow and were treated either with injection cautery or injection clipping, you see that in a hierarchical fashion from spurting down to clot, 27% of them still had residual blood flow when we felt we were finished, which is almost identical to the heater probe group of 24% rebleeding that I showed you earlier from the trial several years ago. Based on that, we did a randomized controlled trial, which has now been published in Gastroenterology, using Doppler-assisted endoscopic treatment as compared to visually guided treatment. It's the same kind of treatment, injection of dilute epinephrine, cautery or clipping, or all three. However, in the Doppler group, if there was residual blood flow, most of the time we were able to administer further treatment. Not all the time. If the investigator felt it wasn't safe, they didn't do it. In this case, of the 148 patients randomized, about 85% of them were ulcers, 12% doulophobes, very few Mallory-Weiss tears. Other ulcers are anastomotic type. So here are the results. The standard treatment in the middle shown by worse stigmata on the top, oozing on the bottom. Among the standard treatment group, 26% of those patients had rebleeding, almost identical to the previous therapeutic trial we did at Cure. And in the Doppler group, it was 11%. Highly statistically significant. The number needed to treat was 7. There are other outcomes looked at. There's some trend towards surgery, favoring Doppler, and major complications paradoxically favoring Doppler as well. No other trials have been published, but this is an interesting study we did with a statistician, which is using patients matched historically two historical controls versus one Doppler patient that had been randomized, treated with the same way, the same techniques, but before Doppler was available. And you see the 30-day rebleeding rate, highly significantly different, favoring the Doppler. Similarly, statistical difference in surgery and a borderline significance of death. Looking at the current standard patients, these are all ulcers, standard patients treated visually, controlled technique versus historical controls 2-to-1. There were no differences in any of these parameters. Rebleed 30 days, surgery 30 days, or death. So treated by the same doctors, the main difference here was in utilization of the Doppler as a guide to blood flow and trying to extinguish it. What else is new? Well, OVESCO has been mentioned. This is a large over-the-scope clip. If you're going to use this for non-variceal lesions, we recommend a diagnostic scope after you've cleaned things up. It's a size 11 3A. It has no sharp teeth. Looking at an example without video, this is a large duodenal ulcer with a visible vessel that had just been cleaned up. We would inject dilute epinephrine 1 to 20,000, and then you see this device is placed right over with centering the visible vessel in the duodenum. It looks like a bear trap. It's somewhat hard to deploy, but they work. Here's an example of what it does to blood flow. So looking in the middle of the 17 patients treated with standard therapy, that is injection cautery, injection clip, or sometimes all three. Blood flow obliteration as monitored by Doppler was accomplished in 76% of the time, but residual blood flow in 24%, and rebleeding by 30 days, 18%. With the OVESCO cases who had Doppler monitoring, 100% of the time the blood flow was gone, no residual blood flow. There haven't been any rebleeds. So as with the previous randomized trial, residual blood flow in these high-risk patients highly correlates with rebleeding to the tune of 75 to 90% of the time. How else has this been used? Well, this is a German study in which the doctors treated patients who had recurrent ulcer bleeding. And these are high-risk patients. Their standard management was not as aggressive as ours, but their OVESCO treatment was similar to what I've described. They found that further rebleeding, defined as continued bleeding at the time of the endoscopy or rebleeding at 7 days, was much, much lower in the middle column, which is the OVESCO group, than it was in the standard treatment group. How you might think of this is kind of interesting. Many years ago in the New England Journal, the Hong Kong group reported these data in which patients with recurrent peptic ulcer hemorrhage either had repeat endoscopic treatment with heater probe or they were subjected to surgery. And what you may remember is because of severe complications, surgery came out looking bad. And so the recommendation for many years has been repeat endoscopic therapy. Of course, we use interventional radiology, but I would suggest that you should use OVESCO on those cases. To varices, what are the independent factors in cirrhotics that make for more bleeding? Well, a higher Child's Pugh score, coagulopathy, gastric varices, hepatomas that you can't remove, and the last one, referral, gastroenterologists doing the endoscopy and the previous treatment. We know that most of these patients, as far as the medical management, get octreotide. I will show you that combination sclerotherapy and banding is the way to go. We don't use tamponade tubes anymore. Radiology procedures are such as TIPS or BRT are considered salvage treatment, and then surgery is not very commonly used acutely. What are the recommendations? Well, we recommend, at least at UCLA and the VA, that the care be in specialized ICUs of these patients so that they be adequately resuscitated. You treat the coagulopathies. There's a parallel treatment by cognitive gastroenterologists and not so cognitive people like endoscopists. Octreotide I mentioned, and then there's a standardization of approaches for the diagnosis and treatment. Patients get prophylactic antibiotics. You have to protect the airway, and then the kind of scopes you use, usually single channel large suction, but you can use double channel scopes too. In regard to varices, you have to remember for esophageal varices, these are in the distal 5 centimeters of the esophagus. There's a plexus, and this is related to portal hypertension. So if you treat 1 or 2 varices and you leave the other ones alone, the other ones enlarge and the patient rebleeds. When you have active bleeding like this, there's 2 options. You can either, if it's so severe and spurting, you can do sclerotherapy to stop that bleeding initially, and then use banding. If you use sclerotherapy to obliterate varices, you have to treat all of the varices, starting at the GE junction after you stop the bleeding, and injecting every 2.5 to 2.5 centimeters above that on each column. If you don't do that, the recurrence rate is high. If you're lucky enough in this case where you can actually band that active bleeder, then you do that and treat all the other varices also. So in regard to treatment techniques for banding, protecting the airway whenever there's severe active bleeding, severe hematemesis or altered mental or respiratory status, it's wise to do that. You band the active bleeding varix first, or if you can't, it fills up the cap with blood, you can use sclerotherapy. Then you have to band each esophageal varix column at or within 2 centimeters of the GE junction, and finally above that 5 to 7 centimeters. The goal is to place 2 bands on each varix. What are the primary hemostasis rates by our unit? If you use banding alone, it's 90%. Sclerotherapy alone, it's 95%. We don't have access to cyanoacrylate, but it's high. But using combination sclerotherapy and banding, we can almost stop 100% of these patients, at least acutely. As part of this randomized study that I mentioned with Doppler, we've also used this on esophageal varices, gastric varices, post-banding ulcers, and hiatal hernia varices, as well as Mallory-Weiss tears associated with portal hypertension. And similarly, in the standard group, where visually guided treatment was used as compared with Doppler, in the Doppler group, you could tailor the treatment and do more treatment. There's a highly significant difference in rebleeding rate, 36% in the standard group, 15% in the Doppler, and you see the data on that. Number needed to treat is 5, and it's highly significant difference. There are other differences favoring the Doppler, including the number of bleeds, the number of transfusions, and even the hospital days. Similarly, we looked at this issue of taking the Doppler patients and matching them 2-to-1 with historical controls from patients that our guys had treated, and you see there's a remarkable difference in rebleed rate 30 and also in death rate. The surgery difference, surgery here was largely transplant, was no different. We did the same analysis comparing standard treatment patients, visually guided as to historical controls, and the only difference here was a decreased death rate, which indicates that the treatment by everyone has improved overall, because this is all deaths. So what about early rebleeding and cirrhotics? How does it occur? It occurs unless all of the esophageal varices in the distal esophagus are obliterated. It takes often 4 to 5 sessions with banding to do this. It can be accelerated if you use combinations, sclerotherapy and banding. What about this issue? What is the failure of endoscopic therapy for bleeding esophageal varices? Well, of course, it's the inability to control active hemorrhage or rebleeding within 30 minutes of the therapeutic procedure. It's a complication such as perforation or severe secondary ulcer, hemorrhage. It is that, thirdly, if you have recurrent esophageal varix bleeding, which can't be controlled within 2 endo sessions or 6 units of blood, that's a failure. If the hemorrhage is from the varices that are not esophageal, that's a problem. And then, of course, if the patient dies. So what I've tried to do is bring you up to date on what the current things we're studying, directions we're going in, as well as an overlay reminding you about blood flow, the OVESCO, and the Doppler. Thanks for your attention.